Welcome, everyone, and thank you for joining us today. Now, before we begin, please note that this webinar is being recorded, and we will have a dedicated Q&A session at the end of the presentation, so please feel free to type your questions in the chat or save them for later. Once again, thank you for attending tonight's webinar on providing a path forward for patients with inherited retinal diseases, hosted by the Foundation Fighting Blindness, the global leader in retinal disease research. We are excited to present this informative webinar, which will take a case study approach to highlight the patient journey and the clinician's role in guiding diagnosed patients. Our presenters this evening include Michelle Glaze, Director of Professional Outreach at the Foundation Fighting Blindness, and Ben Shaberman, VP of Science Communications at the Foundation Fighting Blindness. We are also very honored to have Dr. Erin Kenny, OD-FAAO, as our esteemed speaker this evening. Dr. Kenny is a fellow of the American Academy of Optometry and a diplomat in low vision rehabilitation. She currently serves as an associate professor and chief of the William Feinblum Rehabilitation Center at Drexel University. It is now my great pleasure to welcome Dr. Erin Kenny.
Thank you so much, Andrew. And I just wanted to kind of start this presentation off with just saying I am so excited to present this information. As a low vision rehabilitation specialist, it is so often that we see individuals with inherited retinal diseases. And I think it's really important to highlight that the journey that these individuals go on, there's multiple different paths, and this one is really parallel with low vision rehabilitation and the clinical science behind it and the retinal practice. So I really love this title, Providing a Path Forward, and how that path might be parallel with a lot of things going on. So we are going to start off with a case. I think cases are a great way to set the tone and kind of set the stage of something that a clinician might be seeing in their chair. And, what can we do? I'm going to kind of present it from a low vision rehabilitation perspective. And then we're going to continue to talk with Michelle and Ben, and how Foundation Fighting Blindness can be a partner in this journey for these patients. So Andrew, if you could start us off with this case. The chief complaint is a 44-year-old female, presents to the low vision rehabilitation service with reduced vision in both eyes. She feels her vision is worsening. She describes difficulty with glare, contrast sensitivity, and nighttime mobility. She has a presumed inherited retinal dystrophy that was previously started to be explored by another eye doctor, and she was actually scheduled to see a retinal specialist within the month. So I do have to say this case is inspired by somebody special on this call. This case is actually inspired by Michelle Glaze. So Michelle's going to be talking a little bit later on in the presentation. And I just want to say that Michelle has really kind of inspired me too as a low vision professional of the different options and the different things we can do and how we can partner with Foundation Fighting Blindness to continue with a patient that has an inherited retinal disease. So just kind of breaking down the chief complaint here. It's very common. One of the most common complaints we see in the low vision service is this reduction in vision in both eyes. The concern that her vision is worsening. That's something we always want to take into consideration. Often these inherited retinal diseases or dystrophies are progressive, so that's something we want to keep in the back of our mind. Difficulty with glare, contrast sensitivity, and nighttime mobility. This is something we really want to dive into. We really want to, ask these patients and these individuals these kinds of questions, because maybe this isn't something that isn't normally coming up on a regular eye exam. And like I said here, she had a presumed inherited retinal dystrophy, and she was scheduled to see a retinal specialist within the month. So here I want to highlight how there's this parallel track for a patient like Michelle. Yes, she was continuing on her ocular health journey to come up with that diagnosis or that confirmed diagnosis of an inherited retinal disease. But on the other hand, she has to continue to live her life, right? She has to continue to go through her journey and do her day-to-day activities. So I really love that we were able to highlight that here in this case, is that not only was she seeing a retinal specialist, she was also seeing a low vision provider at the same time to make sure that, we work with her as an individual and work with her for her day-to-day activities. For those of you that don't know, we always say that low vision is a very goal-oriented exam. So when patients come to the low vision service, I really want to know what they want to accomplish that day. What is their vision stopping them from being able to do? So when we talk to this patient, some goals that we had decided upon or wanted to work on would be improve seeing detail up close. So these things might be, seeing the cell phone a little bit better, maybe reading the mail, any kind of small print, maybe out in the community. Menus can be difficult in dark environments. So really kind of figuring out a path for this individual of how we can help with this improving seeing detail up close. She also wanted to discuss options for genetic testing prior to the retinal appointment. So, we had that initial discussion, we had that initial presumption that there was an inherited retinal dystrophy that we wanted to work with. But, what are some options? Could we maybe get the process going before she sees the retinal specialist? Could we get some genetic information before she continues on her ocular health path? She also was having issues with glare. So often with, inherited retinal dystrophies, those rods, those cones, they're very hypersensitive. So glare can be a very common complaint. And this doesn't mean just glare outside. It can actually be glare indoors and outdoors. So we really want to make sure we explore those different environments that they're having issues. And then finally, helping with mobility. So typically in this scenario, I would not be asking a patient, are you having issues with mobility? That wouldn't be the phrase that I would say, but I would say, how do you feel navigating independently? Do you feel that you're having any concerns or issues? Do you travel alone at night? Have you had any recent falls? Those are all different things that I might be asking as a low vision specialist to make sure that I can get this patient connected with the services that they need. So moving on to the next slide, we're going to be talking about the exam findings. So here for this patient, like I said, this was inspired by Michelle. Visual acuity at distance was 20/40 in the right eye and 20/40 in the left eye. At near, at 40 centimeters, which is around 16 inches, she was able to see standard size print of 1M. So when we look at this, everyone might look and say, oh, 1M, that's good. Why is she having details with up close reading? But the thing that we need to remember is often the complaint comes from fatigue or visual strain. So we want to make sure we continue to dive into that to make sure we can provide her with the appropriate devices or compensatory strategies to make it a little bit easier for her. It would not be a low vision evaluation if we didn't check the refraction. We always want to make sure that we have the best pair of glasses that we possibly can for these patients. And then finally, something that we like to do in the low vision service is something called contrast sensitivity testing. This is really, really helpful and can provide a low vision specialist with a lot of additional information that we can help. So for example, the world is not black and white. There are a lot of low contrast objects, a lot of low contrast faces are a low contrast target in the real world. So if we record that we have a moderate contrast sensitivity, I know that we're going to want to explore devices, compensatory strategies that are really going to enhance that contrast to make this patient able to see a little bit better. So the next finding I want to show you is on the next slide here. And this is her visual field. And once again, I have to say, Michelle is so amazing for providing this information for me because this is something that we do see. So you see that really good central acuity, that central vision being 20/40, but she is experiencing this ring scotoma. Another way to think of this is her peripheral vision. She has intact peripheral vision, and then she has this ring of area that she's unable to see, and then very, very centrally she's able to see relatively good acuity. So functionally, this is going to affect her on a day-to-day basis. So once again, this is another thing that we do in the low vision service. We gather all of that information as much as possible. We take her goals, and then we try to come up with strategies and different techniques to help this patient be able to see a little bit better. So if we go on to the next slide, Our plan here, first thing, we always want to update Spectacle RX. For somebody like this, I want to make sure I'm giving them the best possible correction for distance to make sure things are nice and clear, or as clear as they can be. We also want to do a tint evaluation. So the thing about tints, we like to break tints down into two main categories, or when we're trying to evaluate a tint. We look at transmission, so how much light is actually getting through the lens, and then we also look at color. So depending on how the photoreceptors are being affected, different tints and different transmissions might be recommended. So for an indoor tint, maybe we don't want to go very, very dark. Maybe we want to, more transmission. We want more light to be able to come through. And maybe we want to, select a color that would be able to keep those photoreceptors nice and happy, and therefore keeping the patient nice and comfortable. And then when we go to the outdoor exploration of tints, once again, those transmissions, usually these are darker in color. We often like to explore something called fit overs, where we have like a blockage of light above and on the side. And really, every single patient is different. So this is something we do with a lot of our patients, specifically individuals with inherited retinal dystrophies. And then we're going to talk about some low vision devices. So I think people think automatically that low vision just means magnifiers. Magnifiers, that's it. We don't do anything else. And that's really not the case. We have an entire toolbox of different devices that we can utilize to help an individual be able to maximize their remaining vision. So yes, that might be magnifiers. Maybe that is something we explore. We can also use reverse telescope. So that would be expanding visual fields. That's an option that we might have. Also digital, a lot of video magnification can provide the contrast sensitivity that maybe a patient like this would benefit from, just because of that reduction in contrast that we recorded. And then technology. I mean, technology is constantly growing and improving. I say this all the time. Every single patient has a low vision device in their pocket. It is a cell phone. So, maybe something that we would be exploring would be how to change the accessibility features, the different apps that we can work with to help a patient, use something that they already have. So in that situation, we would explore different technology, maybe an iPad, computer, tablets. So that's another realm of low vision that we can work with. I do have to say, majority of our patients, when we see them in the low vision service, it is not a one and done. Usually we have the patient come back for multiple times to make sure that we're able to accomplish all of those goals. And then finally, a thing that we might want to do too is refer to orientation and mobility. So personally, I am not an orientation and mobility specialist, but I kind of find that the low vision optometrist is almost like a gatekeeper in the sense of getting individuals to the right rehab professionals. So for that complaint, or that goal of being able to navigate safely and confidently, that would be a referral to an orientation and mobility specialist. So that's training individuals to safely navigate in their environment. Yes, that often does mean a mobility cane, but it also is other options such as scanning techniques, different ideas on how to navigate routes, and really just feeling confident and being independent in their orientation, knowing where they are and how to get from point A to point B. And then finally, opening up that discussion for genetic testing. As you can imagine, and I'm sure Michelle will back me up on this, it can be a scary time for a patient, just getting this diagnosis. Often there are a lot of questions of, will it continue to get worse? What happens if it gets worse? What caused this? So I find that the low vision provider is often kind of a starting point for that discussion. And it is our job to be knowledgeable and be able to refer to the appropriate resources, doctors, and overall opportunities to make sure patients are well educated on their options and their findings. So with that being said, this is how we would kind of wrap up this case. I would kind of make sure I went through each of those goals. If Michelle was in my chair, I'm sure I would see her a couple of times to make sure we explored all of those different options, depending on how successful we are with different devices in the rehab referral. But this would be definitely my starting point: updating glasses, a nice tint evaluation to help out with that glare, exploring low vision devices based on her vision and her goals, a referral to an orientation and mobility specialist, and then, like I said, having that conversation about genetic testing and being able to really be a listening point for patients that are recently diagnosed or are recently being worked up. So, with that being said, Michelle, can you tell us how Foundation Fighting Blindness can partner with clinicians like myself and retinal specialists and all these other eye providers? And how can you partner with us and patients to make them feel a little bit better as they go through this journey?
Erin, thank you so much. I just want to start by saying I admire your passion for the work that you do. And I'm just really heartened as a patient by the education that you provide to students that are wanting to go into low vision rehabilitation. So thank you for that. And thank you for your partnership with the foundation. As you mentioned, it is terrifying when you receive this initial diagnosis. Many of us have never met anyone with vision loss, and many don't understand what an inherited retinal disease is. I was one of those people. My first question was what can I do, right? Where can I turn? What resources are out there? And I think it's really, really important for the eye care community and the professional community as you work with individuals with an inherited retinal disease to understand the value of continuity of care. As a patient with an inherited retinal disease, we need guidance from our optometrist or ophthalmologist. We need guidance from our retina specialist, from our low vision specialist, from low vision rehabilitation professionals, and we need to be connected to organizations that can provide resources we need as we are going through our personal journeys with vision loss and as vision loss progresses. I think many patients, when they are initially diagnosed, they have some vision, but as the vision begins to deteriorate, we have to have the care of all of those providers in order to navigate and be able to get the support and resources that we need. So you asked how the Foundation Fighting Blindness can assist, and I think that the biggest aspect here is that the Foundation Fighting Blindness can provide knowledge, community, and hope to patients and families as they go through their personal journeys with vision loss. And we can partner with clinicians to share with you all of the different resources that are out there. We can help you connect your patients with others in your local community who understand inherited retinal conditions and are walking through this journey too. And we can provide information about all of the wonderful clinical research that's underway to provide hope for the future. So I want to start by talking about genetic testing, because I think that this is a really important piece, and it is vital for helping patients completely understand their diagnosis and to confirm that clinical diagnosis. So the American Academy of Ophthalmology does see the value in genetic testing. And what the AAO has said is that genetic testing and genetic counseling are essential in the care and management of patients with an inherited retinal disease. And there are a number of reasons for this. It can confirm a clinical diagnosis, which in my case, as you saw, I had a lot of central vision loss. That's not typical of retinitis pigmentosa. When I was first diagnosed, it was thought that I may have a cone rod dystrophy or even Starart disease. So genetic testing helped confirm that I have RP and my genetic mutation is RP1. It can also help to understand inheritance patterns and risk factors for other family members. I'm a mother, I have a son, and so I was very concerned about whether or not my son was at risk for having RP. And genetic testing did help me to understand that my disease is recessive, and therefore he has little to no chance of being impacted by RP. And that was a huge relief, not only to me, but to him. So it's really important. You're going to hear from Ben some of the breakthroughs that have surfaced in the IRD field and a bunch of clinical trials that are underway. In order to qualify for those, in most cases, genetic testing is required. So genetic testing is vitally important for your patients with an inherited retinal disease. I am very pleased to share that the Foundation Fighting Blindness does offer a no-cost option for genetic testing and genetic counseling For those of you in the field, you know that genetic testing can be really expensive. So it's wonderful that the foundation has an opportunity for patients to obtain genetic testing at no cost. The foundation does partner with Prevention Genetics and Informs DNA in order to offer this very holistic approach to genetic testing. This approach does allow patients to better understand and manage their inherited retinal disease. It can help put them on a path forward towards treatments and cures. And notably, it does also help the Foundation Fighting Blindness continue to drive our mission as an organization, which is to find treatments and cures for blinding retinal diseases. Patients are needed for clinical trials are needed for breakthroughs. So this program does help us continue to move the needle and to get more FDA-approved therapies across the finish line. Now, Prevention Genetics offers a 110 gene panel. If you as a clinician are interested in getting set up to offer no-cost genetic testing through this program, please feel free to reach out to us. You can either email PO for professional outreach, PO@fightingblindness.org, or you can email me directly, mglaze@fightingblindness.org. You will have to apply for the program. Once accepted, then you'll set up a portal through Prevention Genetics to order. You can order test kits to be sent to your office, and this is usually done through a buccal swab. Informs DNA is our partner for no-cost genetic counseling, and they're a wonderful partner. I actually utilized Informs DNA for genetic counseling myself. I can share with you that they are very patient-centric. They're very thorough in their evaluation. They not only go through genetic test results, but the professionals that are providing the counseling are very knowledgeable about inherited retinal conditions and some of the clinical research that's underway. So they can help talk patients through trials that they might qualify for and help them understand those test results. About 90% of physicians who utilize our genetic testing program do leverage Informs DNA counselors for genetic counseling for their patients. And then the last part of this program is the My Retina Tracker Registry. And that is provided through the Foundation Fighting Blindness. It is a mandatory component of this no-cost genetic testing option. And what the registry does is enables the research community to identify and potentially recruit patients for clinical trials. It also serves as a platform for researchers to better understand some of the genotypic and phenotypic aspects of inherited retinal conditions. So it's a really important aspect of what the Foundation's mission is, and it does help to continue to drive research and help the community as a whole understand inherited retinal diseases. If you have any questions about this program or need assistance, again, please feel free to reach out to us, and we're happy to help you get set up. In addition to no-cost genetic testing and no-cost genetic counseling, the Foundation offers a number of other resources. I want to go back to that knowledge, community, and hope piece. As clinicians, you really can help support, educate, and empower your patients by offering no-cost genetic testing, by connecting patients to the Foundation Fighting Blindness. We can get folks connected in their local communities to others who have inherited retinal conditions and vision loss through local chapters, which exist in markets all over the United States. We do put out a monthly newsletter where we highlight webinars like we're showcasing tonight, research breakthroughs, and other events that folks can get involved with, both patients and professionals. And we do also highlight all of the wonderful research that is underway. If you visit our website, fightingblindness.org, there is clinical trial information available through articles, through the Eye on the Cure podcast, through a clinical trial pipeline, all of which is managed by Ben Shaberman, who you're going to hear from in a second. He's our VP of Science Communications. So if you'd like to get connected with us, you can scan that QR code on the screen, or you can visit fightingblindness.org/4-I-care-professionals. We would love to connect with you and help you get in contact with the Foundation Fighting Blindness, both nationally and in your local community. So before I hand things over to Ben to go through all of the research that's underway, Erin, I want to turn it back to you and just ask, when you have a patient like me and you're starting to discuss some of the clinical trials, how do you tee that discussion up? And what does that sound like from the clinician perspective for those that might be a little hesitant to dive into research?
Absolutely. And it's a scary time for the patient. So usually how I introduce it is I actually do use Foundation Fighting Blindness as a point for them to actually start to do some exploration on their own. I do think it's important as a clinician that we are knowledgeable about these clinical trials that are out there. And that's actually where Ben has provided so much information in general Foundation Fighting Blindness for me to get that starting point of the clinical trials that are out there and the importance of them. You mentioned it beautifully. It's kind of, we need to have the clinical trials to continue to move forward with, potential treatment options and management of these inherited retinal diseases. So, like you said, I'm sure it's kind of scary, but I like to present the information to them. I always say knowledge is power. So even if I can give you that starting point to utilize those resources such as Foundation Fighting Blindness, it kind of lets that patient process it on their own, but have that resource to look at and to start to go through it. I always say that I'm a partner with them in this. I by no means am a genetic specialist. You mentioned having informed DNA, utilizing the genetic counselors, because I am not a genetic counselor. I'm a low vision optometrist, but kind of telling them as a team approach, utilizing Foundation Fighting Blindness, informed DNA is going to be very, very helpful with coming up with different options and explanations for these patients, and really just letting that patient go through that journey, but knowing they're not alone. So as a low vision provider, I give them the information that I know of, but I also connect them with other resources like Foundation Fighting Blindness.
Thank you, Erin. All
Absolutely.
right. Well, let's bring Ben Shaberman on to talk about all of the research that's underway. And this is the hope piece for those of us with vision loss and inherited retinal conditions. So, Ben, if you want to share all that we have going on, we'd love to hear about it.
Sure. Thank you, Michelle, Erin, Andrew, and thanks to everyone out there for joining us on a Wednesday evening. Just to give you a little context for the research and how far we've come, the Foundation Fighting Blindness was founded more than 50 years ago. And 50 years ago, not only did we not know a lot about retinal diseases, we really didn't know much about how the retina even functioned. And I would say for about 35 years, the research was all in lab studies, in a lot of rodents, canine models, and it was a lot of challenging years creating models, testing therapies in animals, and then preparation for clinical trials. And it's really been the past 12 to 15 years that we've had this tremendous surge in human research. And the foundation now is very focused on moving research out of lab studies into human studies. That's a big focus for us. And we actually invest in companies that are just starting out in clinical development, that are either in early stage clinical trials or moving close to initiating those clinical trials. And excitingly, in part, thanks to our work and also just investment in general, there are somewhere in the neighborhood of 50 companies now that are invested in our space, that are doing development of therapies. Some of these companies are big companies like Johnson & Johnson, or others, and many are small startups. But I have to admit, when I started almost 20 years ago, I never imagined there'd be so much commercial interest in this space. But we need that type of investment if we're going to get treatments over the finish line. And again, as you heard from Michelle and Erin, patients love to hear about the research that's underway for clinical trials. It does give them hope. And as I start talking about just a handful of the trials that are underway, please don't think you have to know all the details of all the trials. But I think to just let people know there is all this research. They can go to the fightingblindness.org website and learn about more research. That alone is very special. And one more comment before I review some specific projects. We as a foundation fund research in gene therapies, cell therapies, gene editing, drugs. Some are gene specific, some are more broad reaching, they're gene agnostic. And we have about 100 projects underway in the US, Europe, and other countries. So there's a lot of great work happening. So let's talk about next here, our big breakthrough that happened in late 2017. And that's the first approval from the FDA for a gene therapy for the eye, not just retina, or really any inherited condition. And this gene therapy is called Luxtera, and it's specifically for people who have mutations in a gene known as RPE65. When that gene is mutated, it usually causes labor congenital amaurosis, which is severe vision loss really at birth or in infancy. Now, just one thing to keep in mind, there are hundreds of genes, each of which, when mutated, can cause a retinal disease. This is just for one specific mutated gene. But what this treatment did, and I'm going to talk about some of the clinical trial results in a moment, it provided affirmation to the research community, the commercial developers, that, hey, gene therapy is in fact an effective way to address these conditions. And when I talk about gene therapy, all we're doing really is we're taking copies of healthy versions of a gene, in this case, RPE65. We're using a human engineered virus to deliver those copies to the retinal cells to replace or augment the mutated copies. This is all done through a subretinal injection, a little drop of liquid underneath the retina. It's kind of like magic. I've been talking about gene therapy for many years. It still seems magical. Anyway, this particular gene therapy, when the trial first started at Children's Hospital of Philadelphia back in late 2007, a few months later, the results were already pretty amazing. And as that trial moved forward, kids and young adults were able to put away their navigational canes, most of them. Many could see the faces of their loved ones for the first time. Some could even see stars in the sky and fireflies. It was just really remarkable. And so Children's Hospital of Philadelphia spun off a company called Spark Therapeutics. Spark raised the money to take it across the finish line. And then a few years later, Roche, the big biotech, bought up Spark. So that's a great financial story for how this gene therapy moved forward. And I'm proud to say that the foundation invested a lot, $10 million, in the preclinical research that really made the clinical trial possible. And again, this was the breakthrough that informed the research community that, hey, gene therapy is a great way to go for these retinal conditions. And just one sidebar here, if you have questions about anything you've heard today, including what I'm talking about, put them in the chat. I should be finishing up in about 10 minutes, and we'll have plenty of time for questions. Next slide, Andrew. Okay, so another condition that's being addressed by gene therapy in earnest right now is X-linked retinitis pigmentosa. As an X-linked form of RP, it usually affects males. It's a pretty moderate to severe form of RP. People, again, males with this condition are usually legally blind by 40. Females are usually unaffected carriers, but we're learning they can be affected as well. So again, RPGR is the gene here, and we're excited that there are two big shots on goal right now from a gene therapy standpoint addressing X-linked RP, again, caused by RPGR mutations. Johnson & Johnson, that big pharmaceutical company, has finished enrolling in their phase 3 clinical trial. That's the last stage before they would seek FDA approval. I expect we're going to hear how this phase 3 went probably in early 2025. If that went well, they will seek FDA approval. Another company called Beacon recently launched their phase 2/3 trial. They're still recruiting. I'd say they're about a year behind Johnson & Johnson, but between these two, hopefully at least one of them will be successful. There is another company, 4D Molecular Therapeutics, that has a phase 1/2 trial. I haven't heard a lot about that in the last few years. I'm still listing it because they still have it on their website. I'm not sure if that's moving forward. But exciting developments, exciting stuff for people with X-linked retinitis pigmentosa. Next slide, please. So there are many other gene therapies in the pipeline, but I want to shift gears and talk about an oral drug that's gene agnostic. And what I mean by that, it's designed to work regardless of the mutated gene causing the disease. And this is really for people with retinitis pigmentosa, Usher syndrome, and those outer retinal conditions. And what I mean by that, the conditions where rods are affected initially, and over time, as the rods degenerate, cones start becoming affected. And what researchers at Johns Hopkins observed in animal models is that when people lose a lot of rods, oxidative stress in the retina really ramps up. And it's a big culprit in cones being affected. It really exacerbates the cone degeneration. And as I think most of you know, cones are really important for reading, recognizing faces, color vision, vision in a lighted setting, central vision. So if we can just preserve some cones in people, that would be huge. So the idea here is to mitigate oxidative stress with this molecule, Knack. And what's cool about Knack, the long name is N-acetylcysteine. This drug has been around for about 30 or 40 years, and it's already FDA approved for a few other conditions, including Tylenol overdose. So we know its profile. We know it's relatively safe. And Johns Hopkins, in conjunction with the National Eye Institute, they've launched a 400+ person phase 3 trial in the US and some other sites in Europe, where they're going to look at Knack in patients over a 2-year period, compare it to a control group, and see if it in fact slowed degeneration. Again, gene agnostic. And in addition to Knack, we helped launch a company called Nacuity that took Knack, and the short comment here is they made it to be even more powerful than the original drug. They added an amide to it. We call it NACA. And that's been in a phase 2 trial in Australia for people with Usher syndrome. We've invested pretty aggressively in this company. So we really have 2 shots on goal for this approach. As I mentioned earlier, there are many, many genes, each of which, when mutated, can cause a disease. So having these gene agnostic approaches are really, really important. Next slide. Okay, so I want to shift gears a little bit and talk about Stargardt disease. So Stargardt disease is an inherited form of macular degeneration. As a form of macular degeneration, it causes central vision loss because, well, it's affecting the macula. And the reason Stargardt disease occurs is because vitamin A metabolites in the retina are not properly cleared, and those metabolites are toxic. So we all need vitamin A in our retinas for our retinas to be light sensitive, and it is processed or metabolized. And I like to use the fuel analogy, like fuel in our cars. I don't know how fuel is processed in a car, but I do know that when it is processed, you have an exhaust system to get the fumes out. In a simple way, what happens in Stargardt disease is those toxic byproducts, the exhaust, if you will, is not cleared, and it accumulates in the RPE cells underneath the retina, and that's what causes the problem. This image on the right, this fundus image that's enhanced with autofluorescence, you can kind of see that crater in the middle where there's been a lot of atrophy and cell loss. And you can see the deposits that have accumulated in the areas around the atrophy. So excitingly, we have two companies with oral medications that are designed to mitigate the accumulation of these toxins from vitamin A metabolism. One is called Alkeus. In their phase 2 trial of a modified form of vitamin A, this is a form of vitamin A that doesn't lead to the metabolites. It metabolizes more cleanly than the normal vitamin A in our diets. In their phase 2 trial, it slowed growth of that area of atrophy by about 30%. Very exciting. They're hoping to go right to the FDA to seek approval and even bypass phase 3. Stay tuned for that. Belite Bio, they have a different molecule that just reduces the uptake of vitamin A into the retina. It's not another form of vitamin A. It's sort of an inhibitor of vitamin A uptake. That's in a phase 3. That's fully enrolled. And we're hoping in the next few months or so, we'll hear results about that. So Stargardt disease, a pretty common form of inherited macular degeneration, at least when we're thinking about inherited retinal diseases. It affects about 30,000 people in the US. So exciting shots on goal for Stargardt disease. And next slide. So we are at about the 3/4 mark of the hour. And I just want to emphasize that this is just a little sample of the research underway, the tip of the iceberg. There's so much more. You can learn more at fightingblindness.org. And we have time for questions if you want to type them into the chat. Happy to address those. And thank you. Thank you all for being here.
I do just want to tag along really quick on something that Ben said. So I'm very, very lucky. Ben has lectured at our low vision service a couple of times along with Michelle. And I do have to say that Ben constantly is bringing new information. And I think it's exciting because that means that the research is continuing to grow and to develop. So this is not something that I feel like, we look at just one time. I think Foundation Fighting Blindness and Ben as a resource has been very, very helpful in that constant development of new clinical trials and new things to explore. So just really, like I said, as a clinician, as an eye care professional, I think Foundation FFB is just a wealth of information of something that is constantly growing and developing.
Thanks, Erin. Yeah, the field is constantly changing. And as I like to say, I'm just the messenger. I'm not there's a lot of great work going down there. I just have the privilege of talking about it.
Right.
And I will say too, just as the research changes, the progression of vision loss, it changes for patients with inherited retinal diseases. When I was diagnosed 20 years ago, I was still driving and I was able to see, and I didn't even realize I had anything going on. Fast forward 20 years and now I am using JAWS and I often am using a cane, and I can no longer see faces. My colors have disappeared. I have a lot of visual noise. And so it's really important as an eye care professional that you're always checking in with patients and you are having them back, and you do share with them how important it is to come to see you as an eye care professional every year, or at least every couple of years. In those visits as a patient, you can, maybe when I first started my journey, I wasn't ready for genetic testing. I was, let's see, almost 7 years in before I got genetic testing. And then, learning about what that means for my family, and then learning about the research, and then feeling comfortable enough with my vision loss to tap into resources in my community and nationally to learn about all the different things that are out there and available to me. That it's a process, and we need the guidance of the whole team, in order to continue to edge us along that path to get the resources we need from all the players. So I think that's important to note.
And Michelle, there's a question. It's a pretty easy answer, I think. Do we have brochures, things that we can physically hand to patients?
Andrew, you want to handle that one?
Sure. So the short answer is yes, but no at the same time. We've actually transitioned away from physical materials to be a little bit more eco-friendly, but everything we have is also in digital PDF format for everyone. And I will actually share the link in the chat for everyone. So these can all be printed off and handed to your patients. And we do actually have additional things as well. And if you would like, please send us a message. I can follow up with everyone, send you additional brochures that we have, informational brochures that we have.
And those are available in PDF format and QR code format. Some of those materials include an overview of Foundation Fighting Blindness, information about the My Retina Tracker program, which is the no-cost genetic testing, no-cost genetic counseling, and the My Retina Tracker registry. We have disease-specific literature about the different inherited retinal conditions in English and Spanish. Information about what to do when a patient's newly diagnosed, and then also information about our professional outreach department, which our whole mission is to help eye care professionals understand the different ways that the foundation can support you and your patients, and different resources that are available, as well as continuing to update you on the research and progress that's being made in the field.
So we have another question. This is a good one. How long does it take for patients to get results of their genetic testing?
So we've recently transitioned to Prevention Genetics for no-cost genetic testing, and their turnaround time is about a month, which is really good. Before the My Retina Tracker program existed, I got genetic testing done at just an academic center, and it took me about 2 years to get my genetic test results. So a month's not bad, and those results go directly to the eye care professional that ordered the test. If Informs DNA was selected as the option for genetic counseling, once that test is complete and reported out, the patient will receive a call to schedule genetic counseling with Informs DNA. And that's done through a telemedicine or telehealth approach. So a patient does not have to travel anywhere. They just answer the phone during their scheduled consultation, which, as you can imagine, for somebody who can't drive, is a really, really nice benefit for us.
And just a couple additional comments about genetic testing. With the technology today, and the Prevention Genetics panel is pretty good, the patient will get a conclusive result about 2/3 of the time. And that's really good if you go back a little ways when it was more of a quagmire. Anyway, about 1/3 of the time, the results will be inconclusive. But that's where genetic counseling really is really helpful. It's also very helpful when it's conclusive, don't get me wrong. But when it's a little uncertain, the genetic counselor can really help the patient understand what that means. And I would say that genetic testing reports in general are kind of cryptic, regardless, again, what the result is. And again, the genetic counselor can really help the patient understand what it all means.
And if I could just kind of chime in there too, as you know, as the eye care provider too, we also get a copy of the genetic counseling report, which is nice because yes, you know, we get that same genetic report where it's a lot of genetic mutations, a lot of letters, numbers, different things like that. And then we get that follow-up genetic counseling report, which is really nice. It's a really beautiful way to summarize what was discussed. And then we have a good understanding of what the patient was told, and we can help reiterate and reinforce those concepts.
Thank you for that ad, Erin. I always forget to mention that, and that's
No,
an
it's
important
very
piece.
helpful for us. Yeah. So usually what will happen is we get a fax report and then we get an emailed report as well. And like I said, it's just nice to kind of have that full picture of what information was provided to the patient. So if there are follow-up questions, we can help them when we can.
And thank you, Erin. And there's another question. Are there resources or opportunities to be involved with clinical trials for some of these treatments? And I guess I want to make sure I understand for the person who's asking this, Daniel Hoffman, do you mean for the patients to be involved or the eye care professional, or both? If you can type that in. Okay, eye care professionals. That's a great question. And I'm a little stumped about how you might get involved initially. Usually it's the patients. What I would say is this: if you're personally interested in getting involved, or other people in your clinic, wherever you are, send us an email and we can connect you with the right people who can talk about what it takes to be involved in a clinical trial. One of the challenges is you need certain kinds of equipment and knowledge. It's a pretty intensive process. Patients have to go back on a regular basis, you know, maybe monthly, quarterly, whatever. And usually the testing is very rigorous. So there might be an ERG, full field sensitivity testing, obviously OCT, visual acuity, all of that might be part of a single clinical trial visit. So you have to kind of be up for all of that. And usually for the trials, the equipment is standardized, so everybody's using the same or similar stuff. But we have people at the foundation who can talk to you more about that. Oh, you're part of a research company. That's awesome. So let us know, and we can connect you with our head of clinical development. And I'm sure he would love to know more about what you're involved in. So that's great. Thank you. Great question. Anything else? And Michelle, can you remind people if they think of something after we log off?
Yeah, absolutely. Thank you, Ben.
Sure.
Yep. And Andrew, you can add this in the chat too. If there are additional questions, again, you can visit fightingblindness.org to review anything that we've shared and showcased today. You can also email us at PO for professional outreach at fightingblindness.org, or you can email me directly, mglaze at fightingblindness.org, and we will respond and get back to you as soon as we can. I want to again thank everyone. Erin, thank you for helping us put this together and for inspiring this presentation. And again, just really appreciate and admire the work that you do and the teaching that you do. when it comes to low vision rehabilitation and resources in general. So thank you for being such a wonderful partner. Thank you to Ben, Andrew, and behind the scenes, Chris, for helping put this together. And Ben, as always, for sharing wonderful information about the research. On behalf of the Foundation Fighting Blindness and our professional outreach team, I want to thank all of you for joining us this evening. And we will be sharing the recording of this session. So please feel free to share that with other professionals who may have an interest in learning more. So have a wonderful evening and good night.